Ms Kerry.
My lady, may I call, please, Robin Swan?
I swear by Almighty God
That the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you for coming back to help us again,
My
Mr.
lady.
Mr Swan, your full name, please.
Robert Samuel Swan.
I dare say it won't be the last time, but I am going to ask you to speak slowly, please, if at all possible. And if I slow you down, please forgive me, but it's important that everyone hears what you have to tell us. You are the former Minister of Health in Northern Ireland. I think you were appointed on the 11th of January 2020 until the 27th of October 2022, is that correct?
That's correct, yes.
And I think, although not within the dates of the pandemic, indeed you were again the Health Minister in February to May 2024.
That's correct.
Right. In your statement, you helpfully set out the pre-pandemic situation where you make no bones about it. You considered that social care was underfunded and in need of reform in Northern Ireland.
That's correct.
And you went on to say, indeed, in Module 2C, that you believed that the social care sector was exposed when you took up your post. You said, I perceived our domiciliary care, our social work, to be the Cinderella service, because I do think they have been undervalued and under-recognised up until that point. And I suspect you still stand by those remarks today.
Very much so, yeah.
It's against that background, then, Mr Swan, that I'd like to ask you some questions about the role you played in the pandemic, and indeed, in particular, what went well, what did not go so well, and what we might do in the future, given now that you're no longer in the department, perhaps some reflections many years on now about what could be improved should we have another pandemic. Can I ask you at the outset, did you, as Minister, know how many beds might be freed up by the hospital discharge policy?
Not at the outset of that in regards to its specific number, no.
Right. Did you know the percentage or proportion of discharges that might end up in care homes, of people that might end up in care homes?
Not at that point, but I do know from subsequent work there has been an analysis of that.
All right. And did you know the percentage of people who might require domiciliary care who were being discharged from hospital?
No.
You say there that you did subsequently come to know. Can you give us an outline of the figures involved?
Well, I think it coming from the Hereditary report, it regards those, non-elective ones, that people who were discharged both to their own homes but also to care home residents as well. In the first 2 quarters of 2019, it was an average 6% of those discharges that actually came from hospital into domiciliary care homes, and that didn't actually change in the first 2 quarters of 2020. Actually, in the second quarter of 2020, the percentage of people being discharged from hospital to a care home actually declined slightly.
Did you agree with the decision to expedite discharges without testing to care homes?
Well, the challenge at that point in time was the availability of testing in regards to the quantity and the quantum that we actually had in regards to that. From what I've seen of the decision taken and the steps taken, it didn't have that dramatic effect on the numbers or the practice. Still very clear from the practice that was involved that all those discharges were made actually on a clinical assessment rather than any drive from a centralised policy that came from a change of policy that came within the department.
From your perspective, who was it who took the decision to agree with the expedited discharge policy?
Well, I'm not so sure it actually was a policy change in regards to that. It was a reinforcement of what would have been done at other clinical pressurised times, should that be winter or those winter pressures that would seen previously. The engagement mainly came in the correspondence that I was aware of and I had sight of before it was actually sent out to trusts, actually came from the Permanent Secretary. Right. Permanent Secretary in Northern Ireland also carried the title of Chief Executive of Health and Social Care as well, so it was a dual titled role.
Right. So the Permanent Secretary sent out the letters that reinforced what you say was an existing policy, but so do we take it that there wasn't you, it wasn't the department, or it was at executive level? Was there any sort of overarching decision within Northern Ireland to agree to the expedited discharges?
It wasn't something that I was asked to agree to, but it was something I was aware of.
All right. Now, we know that initially there was no testing of the patients that were discharged, and indeed initially no requirements for the people discharged to be isolated. Obviously that changed over time. But you are made aware of concerns by particularly members of families of people in care homes about the discharge policy and whether infections were now being brought into care homes.
It was brought to my attention there were concerns in regards to how that was being done and the perception it was done. Some of the language around it by care homes being flooded by people being discharged from hospitals wasn't reflective of the position or indeed what was actually happening in Northern Ireland in regards to that. The guidance actually coming from Health and Social Care Board, I think from around the 3rd of April, was about that 14-day isolation where possible.
Before that isolation guidance came out, though, can I ask about an email that was sent to your office, please? And can we have on screen INQ 256495? This, in fact, 2 emails sent by Martina Ferguson, who's a member of the Northern Irish COVID bereaved group. And she emailed your office on the 30th of March, so before that isolation policy was in place. And she explains in her bottom email that she is writing another email to you as she is a desperate daughter. She said, if someone has passed away in a nursing home since the lockdown has taken place, can they be tested for COVID-19? Can the government exercise all their powers to ensure there is a test? And she makes the point that there were very vulnerable elderly loved ones and staff working in those environments. And a little later on that evening, she in fact goes further and says she's asked you to stop all new admissions into all the nursing homes in Northern Ireland with immediate effect until the visiting restrictions are lifted. And she says she wants to know that we're doing everything we can to help stop the spread of COVID-19 and protect our vulnerable elderly. Did you receive other emails setting out the concerns that Ms Ferguson sets out in that email?
I'm not specifically aware of any other ones, but I am aware of Martina Ferguson. I and her emails and the passion that she brought forward, because I did meet her on a number of occasions in regards to the issues and concerns that she had. This
was a few days into the discharge policy being in force. Did you consider it realistic to be stopping new admissions as at the end of March 2020?
I didn't think it was something that would have been practical at that time in regards to what the intention of that, the discharges from hospitals into care homes was actually about in regards to that, because I was very clear in my understanding that it was only being based and done on a clinical assessment and when people were perceived fit to be discharged into care homes, and it wasn't as was perceived or people were worrying about, that it was an emptying of hospital beds straight into care homes without any care or attention being applied to it.
We understand the decision made clear that there should only be discharges if clinically appropriate. I understand that, but the corollary of that is ensuring there are protections in place in the care home to where you are discharging the patient. Yesterday, the Commissioner for Older People in Northern Ireland, Mr Lynch, told her ladyship that certainly as far as he was concerned, in March 2020, the hospitals, to use his phrase, were pretty empty. And he queried why perhaps there was the need for those discharges in the early stages of the pandemic, why you didn't wait until there was more testing capacity. Are you able to help with, was any thought given to perhaps delaying discharges until there was sufficient testing capacity?
My lady, I think the perception of hospitals being empty wouldn't be a reflection that we had in Northern Ireland in regards to that, because our hospital occupancy was always over and above what was recommended in regards to the use of hospital beds, and sometimes in regards to that clinical assessment for people who are actually physically fit to be discharged to be maintained in the hospital is not good for them either, rather than being returned home. If we had been waiting until testing capacity was up to, and again I think I covered it in the last module, the perception of testing now isn't what it was then in regards to the ease through LFDs or indeed the quantity. Or the ease that was available, and even in turnaround times as of being able to access test results.
Can I ask you about that last answer? And can we have up on screen, please, a graph INQ 000485 679_23? I hope, is going to be a dashboard. There we are. And if there's a misperception about occupancy rates and the like, I'd like you to correct it. But this is general bed capacity. Indeed, in Northern Ireland, you were monitoring ICU capacity as well. You were also monitoring the number of COVID admissions as opposed to general admissions. But if we look at the graph on the right-hand side with the blue and yellow and red on it, one can see there as at April, on the face of it, there is some unoccupied beds within the hospitals, which may be what Mr. Lynch was talking about yesterday. Yep. And I just want to understand, are you suggesting that this graph doesn't accurately represent what was going on in the hospital?
It does, but it is from the start of April. The pre-data, we're talking about those discharges were, earlier on we're talking about March.
Yes.
Actually, from that discharge policy at that point. Sorry if there's a confusion in regards to...
No, not at all, but we've seen other graphs that show a real spike in April of admissions of COVID people and the like. But perhaps before that, there is still, on the face of this graph, some spare capacity with which he would say you could have kept people in hospital pending the availability of testing. Was that something that any thought was given to, Mr. Swan?
Not that I'm aware of, and again, in regard to those discharges from hospital to care home was done when people were deemed clinically fit and the support was there to return them to actually what, if they were to return them to their own care homes where they come from, which would have been the equivalent to being their own home.
Okay. Did you ask Mr. Swan around this time about the capability of care homes to actually implement isolation facilities?
I'm aware there was work done in regards to the RQIA assessing. There was 80 homes that were saying they had the facility to do that in regards to that and being able to isolate somebody to that standard in regards to that. But I think as Professor Holland explained on Monday, that was a desktop exercise in regards to his understanding.
Yes, he thought that might be an underestimate of the number of homes that were able to isolate. But at the time you were taking the discharge decision, had you asked for any work done to ensure that there was capability within the care homes to isolate?
Not that I can recall at this stage.
And at the time the discharge decision was being spoken about and was being rolled out, did you ask whether there may be any other isolation facilities that could accommodate discharges until such time as tests were available?
Well, I think the guidance that was in place in regards to that at that time was that if the care home that the individual was to be returned to didn't have capacity, they were still to remain actually within the trust, and the trust was to do that. So that would have been, I suppose, the equivalent of them staying in a hospital facility if the trust couldn't find an adequate or a suitable place for them to be returned to.
Professor McBride told us this morning potentially of use of some hotels as effectively an isolation facility. But I ask you about this because the Health Committee in due course in Northern Ireland said there was a palpable sense of pressure amongst care homes to admit patients who may have been COVID positive. And indeed, a registered manager of a care home in Northern Ireland told Every Story Matters at that point, everywhere was so under pressure, and we were told, well, they reside in your home, that's where they need to be, they're fit for discharge, we need the bed and you need to take them back. So you didn't really feel like you could say no. Putting those two pieces of evidence together, do you think it was made clear to care homes that they didn't have to accept COVID-positive patients?
I do, in the guidance that was actually given out at that stage in regards to that. The care home always had that option to say no. In regards to the support that we put in, we were also receiving, I suppose, counter to that input from care homes who were concerned about their under-occupancy as well, where we actually had to put in a financial support scheme in regards to homes to make sure that they were economically viable at that point in regards to that. So in regards to that specific quote, it's not something that was brought to my attention at that time.
Did you get any sense when you were Minister, perhaps in the March, April stages, that care homes did feel under pressure, even though the guidance said they didn't have to take a COVID-positive patient, or was that not brought to your attention?
I don't remember in any of the engagements that I had, and I think even from memory in regards to that, I don't think any care home ever contacted me or my office in regards to that to say, look, we're feeling pressurised, can you step in and give us support to say no? I think the relationship should have been that between the care home and the trust who the contract was actually with, to the ability to say we're not comfortable.
In your statement, the Northern Ireland Assembly Committee for Health decided in July to conduct an inquiry into the particular impact of the pandemic on care homes. And I think you're familiar with the report, Mr. Swan. But I'd like to ask you about two of the Health Committee's recommendations, which came out in January 2021. And could I have up on screen, please, INQ 256510_12, thank you. And one of the recommendations, recommendation 15, was that no one should be discharged from hospital to a care home in which they're resident without having tested negative for COVID-19, unless the care home confirms it has the staff and facilities to ensure isolation for the required period, and it's subject to monitoring and review. And I think you responded to that recommendation and were not in favour of agreeing with that recommendation. Could you set out why for us, please, Mr. Swan?
I think, my lady, we partially accepted that recommendation, if my memory is correct, in regards to, I think it follows very much in the last...
Well, I don't want you to guess, Mr. Swan. Sorry. You set out your partial response to the recommendation at paragraph 134 in your statement, if it helps you.
Yeah. And my response, my lady, as paragraph 134 is, we were concerned that refusing to admit a new resident without a negative test, regardless of the care home's ability to facilitate the required self-isolation period, would actually create undue pressures on other part of the system, particularly where the care home has the capacity to facilitate the required period of isolation. But I also advised in the same response that the discharge was an area of policy that the department continued to keep under active consideration.
I just want to understand what you were saying there. You were saying that if they could isolate, then you wouldn't want that to be the reason why a hospital bed wasn't freed up. Do I understand that correctly?
That's correct.
But what if the home couldn't isolate?
Well, then they could stay in the hospital facility, and that's why that recommendation was partially accepted, and that was my understanding.
Thank you. Recommendation 16 was in a similar vein, but not identical, that new residents from wherever they were coming into that, so non-hospital residents, should not be admitted to a care home unless they have tested negative. And I think you also indicated that you didn't fully agree with that recommendation and accept it. Could you help us with why you were not in favour of accepting that recommendation?
And again, it was for the same reason earlier. If the care home said they were able to, or were able to facilitate a new resident who may not have tested positive, could actually accept them into that facility as well.
Right. The Committee for Health's inquiry report said in due course that many homes struggled to isolate, and they gave a number of reasons for that, perhaps facilities as one, staffing issues as another, and indeed the residents themselves who perhaps for their own cognitive state were unable to abide by isolation rules. Was it brought to your attention, Mr. Swan, that there were, before the Health Committee's inquiry report, problems with care homes being able to isolate?
There was concerns, and I think that goes back to, the evidence that Professor Holland gave on Monday in regards to that desktop exercise in regards to those homes that thought they were able to facilitate isolation in regards to that. And I think, as you've already indicated, he believed that was an underestimation.
Just standing back for a moment about the discharge policy, can I ask, from your perspective, what steps did you put in place to try and protect care homes, given that there was no testing, there was very significant concerns that PPE supplies were not getting to on the ground? You had recommended that staff try not to move between care homes, but what was in actual place to protect the care homes, Mr. Swan?
I think was their ability to say no in regards to that transfer, and from previous comments in regards that some care homes expressed a concern that they were being pressurised into that. That was something that I'd have been keen to ensure that they didn't feel pressurised, that it was only in the possibility where they were accepting someone who was deemed medical fit would be transferred into those homes.
Did you know, or was it brought to your attention how many care homes were saying no?
No, it wasn't brought to my attention at that stage.
And if there was the pressure that certainly the Health Committee and indeed some of the evidence we have heard being brought to bear on their care homes, do you think the care home's ability just to say no was a sufficient protection?
Well, if they needed to raise it as well, I think, as I said earlier, the relationship between the care home and the trust with the contractual arrangements should have been strong enough for them to say no. If it's not in future pandemics, it's something I would clearly be in favour of recommending, that there is that strength of a relationship or the ability actually for the home itself to say that.
This may be a difficult question to answer, but just standing back now, do you have any overall reflections on what could have been done better to protect care homes in Northern Ireland?
Well, I think in the early stage, my lady, I would always been of the view that our strength within Northern Ireland was that we were an integrated system. But also from my comments, and I think even in the opening comments from Council, I think there's also weaknesses in regards to that because of that relationship between our adult social care sector being part of the overall budget of that single trust or geographical trust that we have in Northern Ireland. So one of the recommendations that I've now, and it is with hindsight and being able to step outside the role of minister being in there, of our 5 geographical trusts, adult social care was one of the delivery aspects that they had. So it had to compete with financial pressures, budgetary pressures, everywhere else. My concern as well is because that section of the care sector of that trust is so outsourced, when it comes to financial pressures, it's always one of those areas that when finance directors or trusts or boards are looking to balance a budget, it's one of those areas that often gets looked at first because it's the easy budget line to start to remove. So the recommendation that I was actually bringing forward and part of response to the inquiry was that we take adult social care actually out of the 5 geographical trusts and create a single trust for social care across the whole of Northern Ireland. My lady, it's not as big a step. Well, it's a big step probably for some within health and social care in Northern Ireland, but the fact that we're a population of 1.9 million in regards to that, so geographical size of Greater Manchester, population size of Greater Manchester, I don't think it's unreasonable to do. It's how our ambulance service already works as a 6th trust, so it takes all that functionality, all the budgetary control, all the pressures, and puts it into one overarching body.
Now that may be...
Sorry to interrupt.
Not at all.
Wouldn't that then fight against what you say is one of the strengths, so that it's an integrated system?
But it still would be a single adult social care trust still working within a section of the Department of Health under SPPG. So the same way that our Northern Ireland Ambulance Service actually supports the transfer of patients to EDs across every trust in Northern Ireland and has the ability to divert, an adult social care trust that covered the whole of geographical Northern Ireland would then be able to have a consistency of approach, have a consistency of delivery, and should the future pandemic ever put those pressures again, there could be the same level of support, trust and input rather than having a central body, department, RQIA or PHA, having to deal with 5 different trust directors to explain what was needed, why it was put out and how guidance was disseminated.
It may be straying beyond the terms of reference of this inquiry, Mr. Swan, but can I just ask you, what do you perceive the benefit would be in a pandemic of having a one singular social care trust?
I think it actually comes back, I think, to a question that I know Council has asked previously in regards to Professor McBride's evidence about how trusts or even hospitals could support each other or care homes could support each other. So if that was under one overarching umbrella, the ability to do that would be so much, I believe now, so much easier in regards to that. Professor Holland in his evidence talked about, in regards to domiciliary care, about how some parts of Northern Ireland are more challenging in regards to those packages. My lady, what we see is when trust boundaries often come to either side of a village in Northern Ireland, the level of access or the level of being able to access a domiciliary care package can be different, just depending on the postcode of where you live.
We are familiar in the inquiry with the conclusions of the Herity report, which was published in November 2020. And we know that that took data from a very early 2-week period in March 2020 and did not support the hypothesis that hospital discharges were a substantial, I emphasise that word, cause of outbreaks. Given the limitations of the Herity report, in that at least one of the weeks there was no testing at all, and only the second week there was limited testing, can you help Mr. Swan with why no other work was done to try and ascertain whether there was infections seeded in care homes from hospital discharges in Northern Ireland?
Well, I think the Herity report reflected in Northern Ireland work that was commissioned in Scotland and elsewhere, which came to the same basis of conclusion, that although there was seeding and to a level for the hospital discharge into care homes, it wasn't the main or the substantial source of infection at that time.
Staying with the discharges, but just a different aspect of it, can you help with what steps were taken to protect domiciliary care workers who are now dealing with patients being discharged who may be COVID positive?
Well, again, the guidance that went down through their employers, because again, as was it's a highly privatised contracted service in regards to that. It was the advice that was coming, should the PPE in regards to what supports they were given as well.
One of the ways of potentially protecting care homes is to try and restrict staff movement. And we heard from Mr. Holland that there was a pilot that was spoken about called Safe at Home, which envisaged staff working 7 days on site, 7 days off, with a period of isolation beforehand. And he told us why that pilot wasn't able to be got off the ground. But I think you were aware, Mr. Swan, or certainly your office was, that some people were living in, as it were. And can I ask you, please, to have a look at an email 586668_1. And actually the email below that, please, if I may. Thank you. This is the 27th of May, and an email to your office. And it says, we've been contacted by a resident in relation to a particular town. When the lockdown started, the manager had to take leave due to her husband's health, requiring shielding, and a new manager was placed in post. They took over and moved into the home so that she could guarantee a high level of care throughout the lockdown. She's remained there for 9 weeks. The lady called and asked if the minister could visit, and it was pointed out that wasn't going to be possible, it was going to be difficult, even to talk to the manager from the car park. While this may not be possible, perhaps a phone call would be appreciated. The home apparently has not had COVID. Did you ever arrange a call with either this person or indeed someone in a similar position? And if so, what did you learn from speaking to them?
My lady, that was a direct contact to my constituency office at that time. I think inadvertently the response came up where I did go out actually and visit the home, the staff, the manager that we actually spoke to, and her husband was in the car park. It was a car park visit in regards to that stage. Was able to speak to some of the residents indeed through the window. So the care at home model that was suggested, I thought was actually reinforced by this example that we actually had in regards to that, because of the dedication of that individual home manager, or the new home manager that came in at that point.
And can you remember now, Mr. Swan, what were they telling you in that car park about how life had been for them and how the care home was managing to stay COVID-free?
Well, it was specifically in regards to what was, I suppose, envisaged through care at home. Right. If the staff was restricting the footfall in regards to coming in and out. Now, some of the staff were, it was the manager who actually moved in and stayed at that stage, but it gave her that hands-on response. She told me it was challenging, but she thought that was her duty to her I think she talked about her family as how she saw actually the residents in regards to that. The husband to the manager who I spoke to said it had been highly challenging to the family, the fact that the wife had moved out, the mother had moved out for 9 weeks as well, but were very much supportive of what she was doing at that stage. So that's why the care at home model was something that I feel it was attractive, although unfortunately didn't come to fruition.
Did you, just moving away from care homes, did you have any personal engagement with people or agencies that were providing domiciliary care?
To the same extent, I think it was one visit I did when I went down, I think it was the Arch Peninsula, where I actually went to, again, it was a car park of a GP practice where domiciliary care providers were coming to pick up their PPE from a centralised point. At that stage, the trust, rather than them having to drive because of the gain of the geographical area, rather than those care providers having to come into a central area, the trust actually took a facility out, so I took that opportunity to go out.
And what if any... Sorry, I'm going to interrupt you.
No, so apologies. I was just going, at what time, at what stage, I don't recall at this point.
But what did you learn from speaking with the domiciliary care providers?
Again, it was that from domiciliary care providers, and especially in not especially in Northern Ireland, my lady, they see the people who they come in on a regular basis and they get to know them. They're more than just clients. They become regular visitors into the home. Sometimes they were the only visitors that were coming in to some homes in regards to that. So the domiciliary care providers were, I suppose, they were appreciative of the acknowledgement in regards to going out and speaking to him in regards to hearing some of the concerns as well, but some of the steps that they were taking, spending that bit of extra time rather than just their allotted paid 15 minutes in regards to that.
So they were staying on with the people they were looking after rather than a 15-minute visit or whatever the position was.
Yeah, they were just doing that bit, yeah.
Right. Did they mention to you concerns about PPE in the domiciliary care sector?
Well, that was the visit that actually I spoke about in regards to that, was how they were picking up their PPE at that stage. One of the points that, and again, it came through the integrated sector, although we had challenges at the beginning of the pandemic because of the supply lines and the contacts that we had between the independent care home providers, the domiciliary care providers as well, that we facilitated a point of contact within each trust, and that the trust were the linkage to get that PPE directly to them. The decision that we took was that they would be supplied equally from storage when we had the ability to do that and the quantities to do that.
Can I return to where I started on this topic, which was the potential of the Safe at Home pilot? And in your statement, you say you consider the best way COVID could have been prevented from spreading in care homes was by the introduction of the Safe at Home pilot. You said that trade unions' concerns could have been addressed and measures put in place to ensure staff felt safe. Why are you such an advocate for the Safe at Home pilot?
Because I think from that visit in regards to the engagement we had where staff were prepared to do that, we had some care homes who wanted to look at it, but there was that general concern from trade union side, and rightly so, that it was putting additional pressures on staff, unexpected, over and above what they were expected to do, and whether the staff member could feel actually pressurised into do it rather than on a voluntary basis. I know there was concerns raised as well within, I think, from permanent secretary level about the cost and the practicality of being able to do it, but I wanted to explore as to if there were homes and staff willing to do it, should we have been able to facilitate it. I'm disappointed that we weren't able to do that.
Do you still think that might be a model worth pursuing?
I do, yes.
Mr. Holland told us on Monday, I think it was, that looking back, he didn't think it was something that ever could have been expanded in scale for various reasons. Do you agree with Mr. Holland?
Well, I think that is, and I suppose validating my point as well, I think it is something that if homes wanted to do, they should be possibly supported in doing that. One of the things we have in Northern Ireland, I think it has already been referred to, we have a number of smaller homes where the care at home facility could be easier facilitated rather than some of the large scale homes that we see elsewhere across the country.
more generally in relation to restriction of staff movement, did you at the time give any thought to whether there needed to be legislation brought in to try and prevent staff moving between care homes or care settings?
I don't think it was ever raised with me in regards to legislation to prevent that happening, but there were steps that we did take, which I think would have already been covered in regards to the ability for homes and providers to actually block book agency staff as well, so that it reduced the amount of footfall. I think to bring legislation in that would prevent people to do that. I'm not sure how you would start into regards into employment law and the crossover into some of those areas as well as in regards to that. But I do think we took steps in regards to supporting financially those providers, the likes of also additional sick pay as well, so that people weren't encouraged to either go to work when they were feeling unwell, but to prevent that additionality of covering a number of facilities.
A number of witnesses from Northern Ireland have spoke about the ability of care homes to block book agency staff. Was there any specific funding put in place to enable the block bookings? There was a number of financial packages throughout the pandemic that were provided, and one of the things that from the initial, I think the initial grant facilities that we gave in March was like a stipend in regards to the number of beds in each home. You're right. I think it was the 27th of April that there was 6.5 million allocated, and it was on a per bed basis, 10,000, 15,000 and 20,000. But that's the end of April, Mr. Swan. Are you saying that if there was to be block booking, it was to come out of that 6.5 million pot? Well, not at that stage. That was a block grant which was given to homes at that stage, so we could get additional monies to them quickly. I'm not sure that there was that strict of a spend profile put on at that stage, but as we progressed and additional financial payments and supports came throughout the pandemic, it was through engaging with care home providers and the sector as well that they were nuanced, they were put into where we were being told the financial need actually was or had grown, or how we could actually make payments to address some of the challenges or concerns, the ability to block book staff being one of them. Oh. In due course, I think 11.7 million was given in June and then 27 million in October of 2020. Given the increasing size of the funding made available, is it implicit the initial one-off payments of 10 to 20,000 were not in fact sufficient to help care homes? Well, it was about getting an initial payment out as quickly as possible, without with as little bureaucracy as possible. It's still been still recognising that it was public monies that at some stage somebody will challenge the expenditure of. It was also how the department received additional monies throughout the period of the pandemic as well that allowed us to make additional payments. I don't think it was ever envisaged that initial payment was going to be a one-off payment that would suffice through the pandemic. It was always about how, as we get more money, we could actually make those additional payments and support become realistic. Whichever tranche of funding we're looking at, was any of it ring-fenced for either supporting the enhancements to statutory sick pay or ring-fenced for PPE, or was it just, here's the money, you spend it how you see fit? No, it was, there was never a tight ring fence put on it, but there was allocations and guidance given as to what pots could be drawn down in regards to different areas. Can I ask you about PPE? We have heard that, of course, the trusts were to help independent care providers who couldn't source their own PPE. What were the funding arrangements in place if a care home provider had to seek PPE from a trust? Was it given to them? Once we were able to get those systems up and running, it was given to them free of charge. My lady, I think, from the Northern Ireland Audit Office actually did a review into that, and I think the price that they put on it was in regards to £54 million worth of PPE was distributed over the pandemic through to care homes and domiciliary care. So it was not an insignificant investment, but it was a necessary investment at that time. You say in your statement that as early as the 13th of March of 2020, concerns were being raised about the availability of PPE with you. And indeed, there's emails you've seen where it's been raised. And can you help with what steps you took to try and ensure that both care homes and indeed the domiciliary care sector had equal access to PPE?
It was, we stepped in at that stage and trusts were instructed that the PPE was to be provided by the domiciliary care providers and the care homes that they had the contracts with. The arrangement was that each trust was to provide a single point of contact in regards to how they could access, where they could access, and that the deliveries would be made via BSO, Business Service Organisation, to trusts, and then trusts. Now, it was something, it was a new system that was created. It was, it wasn't as seamless as it should have been at the start, and again, one of my recommendations is that we should look now to make sure that if there is a future pandemic in regards to that, that those systems can be quickly activated in regards as to how we do that, because again, the contracts between care home providers, domiciliary care providers with the trust, they're responsible for providing their own PPE, but as we saw at that point, you know, that those supply lines quickly dried up. There is a possibility as well in regards to BSO or BSO PALs actually being a central point of contact, I think, as well, or even purchasing, should care homes or domiciliary care providers be able or willing to go through them as a purchase agent, so there could be, I suppose, cost savings in the bulk buying of that. It's something that hasn't been done in the past in regards to that, but something I believe could be looked at in the future.
I think you said in a ministerial statement on the 27th of April that you were ensuring care homes have sufficient supplies as an absolute priority, to use your words, and you wanted to work with care homes to ensure each home had a buffer stock of PPE. But you go on to say that you learnt through the IHCP that the trusts were only making limited supplies available to care homes. There was inconsistency across the region, hence why you then requested the buffer stock was made available. Can you just help us with what you were being told and what you envisaged the buffer stock, how long it would last? What was the arrangements?
I think that the initial arrangement was that on what they had been using or what they had been drawn down, there would be a 2-week buffer stock provided in regards to that. Each care home, each domiciliary care provider, so that should there be a difficulty in supply within the trust, either the trust supply chain or BSO supply chain, at least they had something to be able to keep them going until whatever concerns or problems could be rectified.
Just thinking about PPE in relation to unpaid carers, I think you said trusts had to continue to supply PPE where they already did so to unpaid carers, and to ensure that anyone in receipt of a direct payment or had a named worker receive PPE. But you go on in your statement to recommend a central registry of unpaid carers, or at least a register to be maintained at trust level. Why do you think that a central registry of unpaid carers would help?
Because I think, well, I know, my lady, that during the pandemic that the identification of unpaid carers was extremely difficult from us, from a central point of view, in regards to those who needed not just PPE but also at later stages when it came to access to vaccines as well, in regards to that as well. So we didn't have and still don't have that central registry of unpaid carers. People can come forward and identify themselves as unpaid carers to trusts, individual trusts, and they go on a register there where they receive updates in regards to what's happening or what other supports are there. But I believe that if we had a central register where unpaid carers could be encouraged to apply to it, but also identified through healthcare providers in regards to the additionality that they're supplying as a care provision to a loved one or a family member, that they could also be identified as well. Because during the pandemic, when we wrote out to actually indicate what support was available to unpaid carers, we actually had to send a leaflet to every household in Northern Ireland because we didn't have that central register. So a central register would allow the dissemination of information, of supports, a lot easier in regards to that. And again, my lady, going back to the size of Northern Ireland and our ability to do something like this, I don't think it's beyond our capability now.
An essential register held by the Department of Health?
By the Department of Health, yes, or if there was a single adult social care trust across Northern Ireland, my lady.
Do you think, though, there may be challenges to defining who is an unpaid carer, and indeed a fluidity to who may be an unpaid carer? They may be only an unpaid carer for a set amount of time whilst their relative is recovering.
There would be a fluidity as well, but also, working through the Department for Communities in regards to that, or indeed some of the organisations that Carers NI who we were able to support during the pandemic as well. It wouldn't be beyond the ability to do that as well, and especially in regards to that fluidity. Somebody who's an unpaid carer for a very short or a shorter space of time shouldn't be neglected by the system either in regards to being able to access that additional information or supports.
I've asked Professor McBride about testing in detail, so I won't ask you, but can I just ask you this? I think you've seen in your bundle a letter from Copney in October of 2020 where the Commissioner was urging you to test staff weekly rather than fortnightly, as was the regime in place at that time. And he told us that he was calling for the weekly testing to try and prevent the spread, which rose then as the autumn progressed. And he said generally overall, though, he thought that you were playing catch-up with testing at the time. Do you think that's a fair observation made by the Commissioner?
I don't think it's fair, but I do know, again, the passion that the Commissioner did bring in regards to the representation of older people in Northern Ireland in regards to that. We were testing on a frequency that, again, was recommended through the expert advisory group in testing in regards to how often and who we were actually doing in regards to that. Because there was also that concern raised about the personal testing of people. At that stage, it was still PCRs, my lady, so it was swabs up noses and swabs down the back of throats in regards to being able to do that for older people on a continual basis. There was a discomfort in regards to that, and the frequency had to be balanced with, I suppose, the positive results that it would give in regards to the usefulness of that frequency as well.
He went on to say, from his perspective, there didn't seem to be, quote, a huge appetite for testing, particularly in care homes settings. Do you have any observations on that?
I would, my lady. I was very passionate in regards to testing and PPE and support and vaccination in regards to our care homes, and I think the department and those who've presented their accomplishment will know that it was something that I was keen to progress at all opportunities.
Aside from the policy, I'd like to ask you, please, about some evidence the inquiries received from a manager of a Northern Irish care home. Could I have on screen, please, 587747_5? I have some water. And can we see there at paragraph 9, the care home manager provides a lengthy answer about the practicalities that were happening. At that stage, testing was weekly for staff and every 28 days for residents, and then other ad hoc testing. They said, in relation to testing, staff required to be trained to ensure adequate technique and errors did occur due to illegible writing or incorrect personal details. The Public Health Agency put out a video to try and facilitate this. And they say, but testing was time-consuming for residents, many of whom could not cooperate or had difficulty tolerating the swabbing that you've just spoken about. Extra staffing was therefore required, and this had great implication on resources that were already overstretched. And there needed to be an allocated testing area to manage the sheer volume of testing to reduce the risk of cross-infection. And then even under that, problems then set out there with the courier collection service and results being slow to return. Were you made aware of on-the-ground problems and indeed things that needed to be overcome by care home managers? And if so, what did you do to try and alleviate those problems?
In regards to the issues raised are not something new in regards to that, and that's why some of the funding pots that we actually spoke of earlier on in regards to that was actually to allow additional time and space and even facilities for staff members to be able to carry out those tests, and the administration connected to that as well. So it was part of some of those funding packages that were actually given to care homes.
You say, you acknowledge in your statement that domiciliary care testing and indeed asymptomatic domiciliary care staff had to wait till the capacity was in a position so you could roll out testing for them. And indeed, we heard from the CMO this morning that that was the position. But you say in your statement that you would recommend that the inquiry should include a direction as to how to prioritise tests in any future pandemic. What did you have in mind, and how would that help the position in Northern Ireland?
Well, I don't think it's just in regards to Northern Ireland. I think in any future pandemic, I think the pressures that we saw, and again this inquiry has looked at, is about how you prioritise and when you prioritise what can be a new set of tests or a new testing regime. What we were doing was doing that under pressure as testing, I suppose, expanded or changed from PCRs to LFDs. On reflection, if that work had been done earlier, in peacetime rather than wartime, in regards to who could be prioritised, when they could be prioritised, and as ability scaled up, that people could be identified. So there is a clear understanding, because while I'm here talking about the pressures that we were getting on testing from within our own sector, within health sectors, I was also receiving pressures from the Economy Minister, who wanted to ensure that all power station workers were tested regularly, from the Justice Minister, who wanted to ensure that all prison officers were tested regularly and all prison inmates were as well. So I think taking the opportunity now to look at how people could be prioritised depending on the nature of the pandemic, I think could be a useful use of time.
Oh, sorry, I didn't mean to interrupt. Would you need to know the characteristics of the disease to do detailed prioritisation planning?
But there could be multiple prioritisations in regards to if it was a respiratory disease, most likely to affect older people, or if it was a viral disease. My lady, I'm not a virologist, nor would I claim to be, but I think there could be a...
So you'd have a set of plans?
And I think it's one of those... Sorry, my lady, I didn't mean to interrupt. No. In regards to that, I think one of the challenges that we had, and it's often the line that's used, was we didn't have a guide or a rule book to lift off the shelf in regards to this. So, it wouldn't take... Well, sorry... it wouldn't take an awful lot of heads, I think, to come up with a number of scenarios in regards to that. I think one of the biggest regrets, and I think one of the challenges in regards to that, is those mass testing facilities that were created across the United Kingdom that we were able to use. I think I've seen a lot of them now stood down in regards to that because of the economic decisions in regards to keeping those almost, in standby in case they were needed as well. So there's work to be done there.
Sorry to interrupt.
No, not at all. You say it wouldn't take that many heads. Whose heads? Which department? Who should lead this work?
Well, in regards to who could lead in that, SAGE, there's a number of bodies out there who could... chief scientific advisors from across the jurisdictions in regards to that. There'll be a number of, or academics in regards to university input too.
Can I move on to visiting as a topic, and two discrete topics here. One is in relation to end-of-life visits, and at your paragraph 287A, you make reference to the principles for end-of-life care that were included in the UK government's updated principle. I'll just wait for you to get there. It's at your page 93, Mr. Swan.
Okay.
11th of May 2020, there was guidance put out which meant that essentially end-of-life visiting was deemed essential, but that was not replicated in Northern guidelines. And I wanted to try and understand with you why end-of-life visiting was permitted in the UK, but that wasn't repeated in the Northern Irish guidance.
I think in regards to visiting, the Chief Nursing Officer was very clear in regards to facilitating end-of-life visiting in all areas where it could be safely done as well.
We know that your statement sets out a number of concerns about the visiting policy from both the perspective of the resident and the impact it had on them and their loved ones, and indeed the impact it had on the care homes who were trying to reduce the ingress of transmission. You said, I think, in your statement as an overall reflection that you considered the decisions taken in respect of visiting were not 100% right. In what ways, Mr. Swan, were they not right?
In regards to, I suppose, the restrictive nature of them, and just how restrictive they were at the beginning as well in regards to that, and I think that's where our development in regards to care partners has allowed to ease that restrictive nature as well in regards to just how quickly that initial lockdown actually shut down visiting as well, because it was, I know it's been said elsewhere, but it was, and it still is my belief, our care homes are our residents' homes, as well as being those health facilities as well as in regards to that.
I think the Commissioner for Older People was a powerful advocate in terms of trying to increase the number of visitors in care homes. And but there was potentially problems, was there not, Mr. Swan, with the implementation of the care partner model. From your perspective, what were the impediments for rolling out this model across the care homes in Northern Ireland?
I think there was a concern from some homes and some of the management in some homes as to what it actually meant in regards to increased footfall and I suppose the chance of increased positivity in regards to testing in regards to that as well. It was a reluctance that I find challenging in regards to that, as in regards to what we wanted to do in regards to the implementation and the delivery of care partners.
Clearly, though, the counter-argument is we don't want more people in our homes, it might bring in more infection. The CMO told us this morning that there wasn't testing written into the care partner guidance because at that stage there probably wasn't capacity given the increase in the numbers of COVID infections. Did you think that there should have been more guidance put out about the role that testing could play as a reassurance for care homes that infection wasn't coming into the home?
I think it was, now, I don't have the document in front of me, but from recall, I think in regards to the leaflet, it was clear to care partners that they may be expected to take COVID tests in regards to that, should that be a requirement of, they were added along with the staff testing regime at a later date when that capacity became available as well. But I think just to strengthen in regards to where I saw care partners or where we saw care partners, it was about relationships between the care partner and not just the person they were supporting, but also the relationship with the care home and the care home management themselves. Because I think we can look, I suppose, too quickly or too easily that relationship was only between the resident and the care partner, whereas in many homes, the relationship between the management, the nursing staff, the support workers, with somebody who may deem themselves a care partner is actually maybe as strong or as important in regards to the additional supports that can be given to those residents.
I think you have seen a number of letters from the IHCP expressing their concerns about the care partner scheme, particularly in November and December 2020. I won't go through them all, Mr. Swan, but can I summarise them in this way? They were worried about the greater the footfall, the likelihood of a rise in transmission. They were concerned about the definition of a care partner, and they were also concerned that whilst understandably the family's views had been listened to, the care home providers' views about the feasibility of care partners hadn't been listened to. Do you acknowledged the concerns of the IHCP, and do you have any observations to make about their concerns?
The IHCP did raise those concerns as well, but to counter that as well, we announced the Care Partner initiative early September, I think it was, or sorry, in September, and I think within days of that being announced, we were contacted. The home I remember it was Spa Care Home, which is a small village in County Down, which had a care home who were in contact to see how they could do this. They really wanted to do it. They wanted to be part of it. So when it came to that engagement over that 6-week period before implementation, there were a number of homes, a number of I suppose stakeholders in regards to that we worked along with in regards to making sure it worked as efficiently and as easily as possible for those homes and those individuals who wanted to make it work.
We know from Mr. Holland that there was varying numbers that rose throughout the pandemic of care homes that did roll out the care partner model. And when I asked Mr. Holland about whether there should be legislation perhaps to try and make it mandatory, he said, in fact, he thought that the contracts that existed between providers and the trust might be the lever, and thought that there had been a reluctance on the part of trust to use the contract with the care home to influence care partner practice. From your perspective, did you take any action to enforce the contractual obligations between care home provider and indeed the trust to bring in the care partner guidance?
Well, it wouldn't have been within my remit as the contracting authority.
I follow that. Maybe I phrased it badly, but did you try and encourage the trusts to take action to enforce the contracts?
Through RQIA, there was, an encouragement in regards to supporting homes in regards to that. There was also additional monies put in to supporting care homes as well. I think in the package of 27 million that we provided around the October time, also the support of care partners was there as well. Building on using that contractual is actually one of the recommendations that I put forward again to the inquiry was actually putting that care partners relationship or opportunity actually in legislation.
Yes.
In regards to that, because again, I think rather than having to rely on contracts or interpretation, a facility like that I think has a benefit in regards to being actually in legislation.
You've referred earlier in your evidence to some of the funding that was granted to care homes. And indeed, I think to be eligible for some of the funding, the care home had to confirm they were implementing the care partner guidance. Can I ask you, though, if for legitimate reasons, any care home wasn't able to implement the care partner guidance, did that mean that they didn't get the October tranche of funding given to them?
No, it only meant they weren't eligible to the allocation that was for the support of the care partner scheme.
Can you help us outside of care homes as to a summary of support provided to domiciliary care? And I think I'm at your paragraph 357, if it helps you, Mr. Swan.
Sorry, yes.
So forgive me.
You're okay.
The support provided financially to domiciliary care, would you be able to help us with what you put in place?
Well, again, coming from that paragraph, alongside the provision, which was worth, in regards to the figure that's there, the 41 million, it was again about support to independent domiciliary providers under that arrangement where the providers had their income supplemented, actually to be 100%. So if there were care packages actually cancelled, which we did see during the pandemic, that their income was still supplemented to that to make sure, again, that provision was still there and that domiciliary care providers, when we saw packages being cancelled or handed back because people were staying at home, working from home and cancelling packages, that we didn't actually lose the workforce either. There was also the 80% payment towards domiciliary workers should they have indicated that they had either tested positive or had COVID symptoms, so that they didn't feel that they were going to be financially penalised for not coming into work as well. So that additionality was there too, which was replicated across the care home sector too.
In your statement in relation to unpaid carers, you say that I think on the 19th of April, there was funding of 4.4 million to support unpaid carers, which was to last until March 2024. Can you help with why specific funds to unpaid carers were not put in place until April 2021?
My lady, the financial opportunity, again, because we were unable to identify unpaid carers, so the ability to actually give them the £500 bonus that we were able to give not just all healthcare workers but also care home workers and domiciliary care workers. I wanted to explore another opportunity as to how we could support them, so it actually came through a tranche of monies that the department was able to bring down, that we put into a very specific pot to support unpaid carers through an unpaid care support fund. It was a pot of 4.4 million that was allocated to Community Foundation Northern Ireland, that organisations were able to apply for to support them. Carers NI and a number of other voluntary and community organisations were able to do that. I did that through a ministerial direction, my lady, at that stage, because the Permanent Secretary wasn't able to prove value for money through governance arrangements as elsewhere in the. It wasn't that he was opposed to it, that it was necessary for me to direct them to do that, to make sure that that money got out in some way to be able to support our financial carers. So because it was, I suppose, COVID monies, it was for 3-year projects, and that's why it was specifically for that time frame as well. There has been extensive representations made, I know, to the current minister as well, in regards to being able to find funding to extend some of those projects because of the value, but I'm not sure he's going to be able to do that.
Right. One of the contributors to Every Story Matters, who was an unpaid carer living with a person they cared for in Northern Ireland, said this: "At one point, I was probably only getting about 4 hours sleep a day for months, and it just became the norm. I thought I was all right, but I was absolutely exhausted. And can I ask, please, that we call up on screen INQ 176237. This is from a Carers Northern Ireland report called Caring Behind Closed Doors. It came out in April 2020. And if one just looks to the column on the right-hand side, they conducted a survey of over 420 carers in Northern Ireland. And the majority, 64% of carers, agreed or strongly agreed with the statement, "I feel overwhelmed and I'm worried I'm going to burn out in the coming weeks." Their biggest concern was what would happen if they themselves became ill. The overwhelming majority, 87% of carers, strongly agreed with the statement, "I'm worried about what will happen to the people I care for if I have to self-isolate or become ill." Aside from the funding that came into being in April 2021, what steps did you take to try and mitigate, as so far as you were able, these pressures on unpaid carers in Northern Ireland?
My lady, in regards to, I suppose, the comments that are seen there, it was replicated extensively across society in Northern Ireland, especially in regards to our unpaid carers. The funding allocation was what was available in 2021. Prior to that, again, it was working through voluntary and community organisations through their core funding and being able to see how we could support those unpaid carers. Again, come back to, I'm not meaning to repeat myself, my lady, it was the identification of those individuals and those families proved actually difficult and challenging at sometimes in regards to that, and that's why I do think we need, again, that central register so that we can get those guidances, supports actually into place as quickly as possible.
You mentioned in an answer a moment ago reference to the £500 special recognition payment to health and social care staff, which I think was announced in January of 2021. I mean, can I have up on screen, please, INQ 597566_1. This is an email dated October 2021 to you, and it includes a number of pieces of information. But if we go down to the section stated £500 bonus payment, this is a home care provider who sets out their difficulties, and she says the £500 bonus payment is still outstanding. She advises that health trusts have not been engaging with providers. She say they set criteria that providers can establish from their payroll who would qualify. Could payback clauses be built in? Why not adopt such a system? And if we just go down, I'd ask that the overdue £500 bonus payment for carers is urgently addressed, and that with new national insurance contributions to health and care society, we should value the vital role that carers carry out. Were you aware that there was such significant delays now of 8 months or so in that special recognition payment being made to the people it was intended for?
Yes, and I did ask for regular updates in regards to that because, again, of that contract nature of the workers working in domiciliary and care homes as well. It was the providers had to put in payroll, put in claims, and then it was put back out as well. But in regards to the point of the national insurance, that was actually matched as well. So it was a £730 whatever pound as well, because what we actually put into pay packets for those eligible was ensure that they got £500 on their bottom line and not that they lost national insurance or tax out of it. And that was supported through executive colleagues and the finance minister as well.
Do you know whether the £500 payment did speed up and get to those on the ground?
I know there was challenges for it. There was, the number of options that I was given at that time when I decided to follow this route. There was, I suppose, those simpler automatic, a simplified system that would have been easier, but the £500 was one that was eligible across all individuals in regards to that. So I know there was a small team worked very diligent in regards to making sure they could get as many payments out as possible for people who weren't on trusts' payrolls. So in regards to this was where we had to identify through third-party providers who was eligible so they could receive it as well.
Perhaps one other topic, if I may, before the afternoon break. Thank you, my lady. And may I ask you, Mr. Swan, about DNA CPRs? And in your statement, you said that you were aware, following articles in the media, about the concerns raised in relation to DNA CPRs. And I think in March 2021, you were asked formally how many local audits had been undertaken since the start of the pandemic to monitor adherence to policies and guidance in relation to do not resuscitate orders. And the response was that 2 health and social care trusts are currently progressing audits. Did you request the audits to see what the audit found?
They weren't requested specifically by me, but I do know they were been. But on the back of, I think it was a written question from Wally Humphreys, who was one of the MLAs, yes, in regards to that. That was the answer that came back. For regards to the blanket imposition of DNA CPRs, I was very clear in regards to answers as well, that I thought any sort of blanket application would be discriminatory and unethical in regards to where I stood.
You, I think, gave similar evidence to Her Ladyship in Module 3, where you said that orders based on age or disability were discriminatory and unethical. And you said, in terms of the policy in Northern Ireland, media reports were ill-founded, and you said you'd been given insurances based on an information pack that had been provided to you. The inquiry instructed some end-of-life care experts, Professors Sleeman and Barclay, and they've stated in their report that they were unable to identify any systematic evaluation of DNA CPR form usage in Northern Ireland. And indeed, the learning disabilities experts could not find any Northern Irish material relating to DNA CPRs and people with learning disabilities during the pandemic. So can I ask you then, given that there were the concerns that we've heard about, on what basis do you say, absent an evaluation, that media reports were ill-founded?
Well, I think in regards to the feedback that we had, and again, the information pack that I referred to was actually on, and I've been able to get it since that session, is on the information pack that was actually behind that written question in regards to what was being done. So in regards to the Belfast Trusts, Their mobility and mortality review that they did every month looked at all DNA CPRs as well, so they were doing that as well as work being done by the Western Trust as well. I know it was an issue that Copeney, the Commissioner of Older People, also raised, but in his statement, I believe, where he has raised concerns, he said the concerns that were brought to him were again in only single figures in regards to that.
In your Module 3 evidence, you also observed that you thought there was now an opportunity to retrospectively conduct an evaluation and made recommendations in that regard. Do you know, and I appreciate you're no longer in the Northern Irish government, whether anything has been done to conduct such a systematic evaluation?
I'm not aware, apart from what I've heard from Professor McBride's evidence this morning, my lady.
Right. My lady, that may be a
Certainly, I shall return at 3:15.
Thank you. Thank you, my lady.
Let's go.
Mr. Swan, the inquiry is familiar with the changes made to the regulatory inspection regime in Northern Ireland, and I think you say upon reflection you consider it was appropriate to direct the RQIA to reduce its statutory inspection activity and indeed to suspend its non-statutory inspection activity. But given the suspension, indeed reduction in that activity, what assurance did you receive that the residents of care homes would be safeguarded in Northern Ireland?
Well, I think in regards to, even in regards to this response that I gave to the joint letter from Copeney and the Northern Ireland Human Rights Commission in regards to that RQI's statutory inspections actually weren't suspended. They were still being carried out in regards to, my lady, I'm actually aware, there was one home where RQI was actually stepping in regards to such a concern that they had over residents that we were looking about not just putting on impositions in regards to the home, but actually moving people out of that home. To such was the extent and the concern as well. So it was about a reduction of statutory inspections rather than the complete suspension.
Yes, a reduction of statutory, but a cessation, as I understand, or suspension of non-statutory inspection activity. I'm sorry if I didn't make that clear, but that's what you set out at your paragraph 439 in your statement. But whichever it was, whether it was a reduction or indeed a suspension, what I'm trying to get at is what steps were you happy with that were put in place to ensure quality of care insofar as it was possible in the pandemic, and indeed that residents were safeguarded?
Well, there was, there was in regards to that, the reporting from the care homes to RQIA through the establishment of the app, but also in regards to the supports through trust workers actually being put in to supplement care homes where they didn't have enough staff to do that as well. So there was that footfall as well as in regards to that. But I think looking on the repurposing of that staff in RQIA to the service support team, I also think give that bit extra to care home staff and management as well.
That was a supportive, primarily though, system that was set up. Given that there was a reduction in the number of visitors and loved ones that we've heard of, indeed potentially some reduction in professionals going into care homes to look after the residents, were you satisfied that the service support team, or SST as we've been calling it, was capable of being the eyes and ears as well as providing the support that we know the team did?
Well, I think they were, because of the professional qualifications and the professionals that they were as well, because care homes and care home staff were actually contacting them about concerns as well. They had, in my opinion, they had the ability that would have been able to flag concerns in regards to the questions that they were being asked in regards to what certain care homes or what certain care staff were asking in regards to those concerns as well.
You say in your statement that you thought that the support established, in fact, was of such importance that you should it should be considered as whether to set it down in statute. Why do you think the SST or an equivalent scheme should be put into legislation?
I think in regards to the ability that they were able to provide care home providers, sorry, specifically in Northern Ireland during that time, actually has been cited by other representatives to the inquiry, actually from England. I think it was Miss Townsend, in regards to their feedback from their care home suppliers, that the feedback they got that the SST in Northern Ireland provided a service over and above what CQC was actually given in regards to that, and was seen as a positive as well. So I do say in my recommendation that such a team should be stood up, as were critical response units and centres across other departments, and even including the Department of Health, that such a facility staffed by professionals outside one of the main bodies where people could go ask for assistance, clarification and guidance would be useful as well. I know I'm clear as well that such a body doesn't necessarily have to come in the future from RQIA.
May I ask you about two discrete areas of data, and in particular data in relation to dementia patients. Professor Banerjee, who gave evidence, expert evidence to the inquiry, said that despite dementia being very common, it did not explicitly get mentioned in key policy documents for the first 9 months of the pandemic, even notwithstanding the fact that there were a disproportionate number of deaths of people with dementia. Does his observation that dementia did not get a mention in key policy documents in 2020 hold true for Northern Ireland, do you think?
As far as I'm aware, that would be an adequate reflection, and it's regrettable as well.
Did you call for any data in relation to the proportion of COVID deaths in people with dementia?
Not that I can recall specifically at this point.
Second aspect of data is, in your statement, you said there should be a core data set for domiciliary care during the pandemic, agreed across the trusts and regional agencies. And I wanted to ask you why you thought there should be such a core data set, what it should include as the core data, and who should collate it.
Well, again, at this point, RQIA could be an option as facilitating that, but not to be repeating, if there was a single trust, single adult social care trust in across Northern Ireland, there would be such a set that they could hold, as well as in regards to that, as regards to, I suppose, the physical and mental conditions of the people who the domiciliary care providers were going into, to actually what conditions they were supporting people with. And
what data is it that you think would be of assistance in a pandemic?
Well, it goes back to that point, I suppose, going back even to M1 and M2C in regards to the lack of accessible data that Northern Ireland actually had at that point as to one collection point. Now the introduction of Encompass will move some way in doing that, to have that central allocation, but it's something that wasn't there at that point. So again, it goes back to, if, and I hope there isn't another pandemic, it goes back to my lady's point, if it's a different condition, a different virus, working in different ways, affecting different cohorts in different ways, that they can be easily identifiable so that support and assistance can be given.
All right, so clearly, obviously, you need effectively to know who is acting as a domiciliary care worker, and I dare say which region or trust within which they're working. But is there anything else that you particularly think that the core data set should include?
Well, it could actually include all Section 75 criteria that applies to Northern Ireland in regards to ethnicity, gender, age profile, because not everyone receiving domiciliary care is aged in regards to that. So there are a number of young people in regards to even young adults who receive those packages too.
One of the overarching observations you make was that in addition to saying that decisions in respect of visiting perhaps were not 100% right, you said decisions in respect of PPE were not 100% right. In what ways, Mr. Swan, were they not right?
I think in regards to the speed and the distribution lines that we actually had when we moved to ensuring that centrally held BSO trust PPE was accessible to all sections of people delivering care in regards to that. The people that you talked about earlier on, those unpaid carers, people in receipt of direct payment as well, so that the central register can actually identify them as well.
Just finally, before I finish, two things, please. Copney, in their statement, the Commissioner said this: In my view, the government's failure to properly grapple in its policy and guidance with the lack of PPE, the imposition of lockdown without ensuring that there were adequate staffing levels, and the need to provide COVID-19 testing of older people and those working in them created a perfect and fatal storm in care homes. There was a similar concern for older people locked down or isolating in their own homes and reliant on domiciliary care. Do you consider that there was a failure by the Northern Irish Government to grapple with the policies in relation to both care homes and indeed the domiciliary care sector?
I think expanding on Copenhagen's statement in regards to that, I did have to read it a couple of times, because the first time I read it, I thought he was implying that we shouldn't have locked down or went into lockdown until there was adequate staff and adequate testing in regards to those sections as well, which I think would have been actually detrimental to our older people in Northern Ireland and the care home sector as well. But reflecting on what he meant in regards to the challenges that were faced by domiciliary care and our care home sector, as our opening comments have, I remain concerned in regards to the support that has been in place over the past number of years and continues to do that, even though the steps that have been made in regards to even the reviews that have been completed since, in regards to that sense of still a Cinderella service who people look to when they need to, but often are forgotten about in regards to terms, conditions and support as well. And that's why out of the reform of adult social care that I instigated, the Social Care Collaborative Forum, which brings together suppliers, contractors, trusts, RQIA, PHA, all those organisations, actually gives a sound footing in regards to how we can ensure that any future directions, guidances and all that we don't face that storm or those challenges again.
Aside for your enthusiastic support for a social care trust and indeed your comments just made there in relation to a social collaborative forum, do you have any other recommendation that you would urge upon your ladyship that would benefit the adult social care sector in Northern Ireland in a pandemic?
Well, I think in regards to that social care forum that I've suggested was created as well, that actually could be the stakeholder forum to a single trust. My lady, in regards to the otherwise, is actually I think is that detailed support plan for the care sector with clear responsibilities across all who is responsible for doing different parts, different sections. Should it be testing? Should it be PPE as well? Again, come back to that point we discussed earlier, my lady, in regards to taking the time actually to do it now and to look at the various options. Part of the challenge and part of the language used at the start of I suppose this inquiry was from some that we had prepared for the wrong pandemic. It's about using the time now to look at, and I suppose future scan in regards to what could be out there, what could be potentially the next challenge that health and social care or indeed society faces as well.
Can I just ask you, in relation to the separate trust for adult social care, you'll know as a former minister, and in times of limited resources, anybody who wants to suggest a reform or change in some kind of structure has to be careful of what would it cost. Sorry to be so basic. Yep. Have you thought about what the resource implications of a separate trust would be?
My lady, this is taking a service that already exists across 5 current trusts, bringing it into one body. So with directors of adult social care, with 5 directors of adult social care looking after a single geographical area in the population. Whereas I think if you start to streamline that into a single trust area based on the same form and structure as our ambulance services in Northern Ireland, so a trust, a chief executive, it wouldn't be over and above the costs that are already there. But there also could be that then in regards to the cost saving, in regards you've one organisation dealing with BSO for the procurement of PPE. You've one organisation that then can look to HR in regards to the staff that they directly employ, but you've also then the ability for one organisation to be contracting with all the domiciliary care or home care providers, so you're not looking at different contract negotiations for different rates at different times across the entirety of a sector. We have in instances in some towns and villages where there could be 2 domiciliary care providers providing packages for 2 neighbours, where I suppose a more streamlined, a more acute, a more alert management system introduced by that could see the same domiciliary care provider providing the same care for the 2 neighbours rather than 2 different groups of individuals coming in as well. So there could be a level of cost. It's not something that I've done that detail of work on, my lady, but I definitely think it's something there is an option to pursue.
Could I ask you to play devil's advocate for a minute and think, had you proposed this when you were in office, what would the arguments against have been?
My lady, I did actually, and where some of this comes from, I started a review in regards to children's services across Northern Ireland in regards, it was Professor Ray Jones, again working with Professor Sean Holland, and we looked at it about how we could actually again pull all the children's services from different trusts, and also actually coming from different other departments. Now, again, because of the politics of Northern Ireland, when the executive collapsed in October 2020, that work went on the shelf. I know Professor Ray Jones has been keen on getting it reinstated again. So it is about the ability to, I suppose, civil servants and politicians to be able to step back and actually look outside the silos of safety and security and see how a service can actually be progressed and made better in regards to the delivery of the people that they're looking after in regards to that. So there will be, there will be opposition, my lady. There's always opposition to change, but if we don't take the opportunity to change for the better, I think we could lose. We could lose the benefit of this inquiry, my lady, in regards to what could, how those status quo and those silos can be challenged.
My last question on this before Ms Campbell asks her questions. Sorry to keep you waiting, Ms Campbell. Last question on this. Just supposing I were persuaded to make recommendations, supposing the recommendation didn't find favour for the reasons that you've said, is there any way one could ensure that social care doesn't end up as a cylinder, as you say, the low-lying fruit for the budget?
Yeah.
Is there any way you could ring-fence budgets or protect social care within the current trust system?
Well, and I think that should be part of the key remit of the Social Care Collaborative Forum that is now in place and now working as well. Part of that, there's a Fair Work Forum within that in regards to making sure that those staff are properly remunerated as well. And I know the current minister is actually in favour of that as well, so that we go to those domiciliary and care providers, move to the real living wage, so that there becomes a surety in regards to that. But I think it is about that challenge again, about breaking down silos and areas of responsibility. I still believe that Northern Ireland's of a size that we're small enough to be able to do it, but we're large enough to get it right as well if it's done.
Ms Campbell, over there.
Thank you. Mr Swan, good afternoon. You know that I ask questions on behalf of the Northern Ireland COVID bereaved Families for Justice, and although her leadership has granted us permission on a number of topics, we are indebted to Miss Kerry, King's Counsel, who, as ever, is alert to many of the issues of concern to the bereaved and has addressed some of the topics in her questions already. Leaving me to revisit briefly, if I may, the issue of discharge from hospitals into care homes, and then coming on in a moment to deal with visiting and care partner guidance. On the topic of discharge, and going right back to the 17th of March 2020, we know that the guidance for nursing and residential care homes in Northern Ireland that was issued that day gave notice to care homes of the need for them to firstly work closely with trusts, and I'm taking this really from the guidance itself, to work closely with trusts to facilitate discharges from hospital, to ensure the effective flow of patients from hospitals, to communicate vacant placements quickly, and to facilitate the filling of places within care home providers. Can you understand why, on receipt of this guidance on the 17th of March 2020, and her ladyship has heard how hungry the sector was for guidance at this point in time, can you understand why many care home managers may well have felt it was their obligation to free up beds in the hospital sector by filling vacant beds in their own facilities at that time?
And I think on reflection in regards to that, it still goes back to that point that should have been done on clinical decisions in regards to the suitability but also the condition of those people being discharged as well.
Yes, but my question is slightly different. Can you understand why care home managers, fearful for the residents in whatever facility they were managing, felt nonetheless an obligation to accept discharges from hospital on receipt of that guidance in mid-March?
In regards to receiving their own residents back again who had a spell in hospital due to whatever reason, there are many of them I would assume would also want to have those residents back and somewhere where they could provide that care for them, but also in regards to, as I said earlier, in regards to an earlier question, that the hospital in some instances isn't the best place for some of those patients to actually be.
Yes. You were asked by Ms Kerry, King's Counsel, in relation to this discharge policy, what was in place at that point to protect the care homes? And your answer was that it was the ability of the care home to say no when asked to accept a resident back into their facility or a patient back into their facility. Do you think that the March 2020 guidance made that protective measure clear?
I think the March guidance was, I think, even as Professor McBride indicated earlier on, was a repetition of guidance that had already been in place. It wasn't new in regards to that. So when it came to winter pressures, it was a similar guidance that was based on that point as well. And as I said to Ms Kerry in regards to that, I think and I believe that the relationship between those care homes and the trusts is mature enough, that the contact is there, that if they were concerned about receipt or receiving patients, that they could say no, because also the additional provision that was in there as well, that if it wasn't that case, that those patients were to remain in the trust's care until they could find a suitable placement for them.
See, we're of course in very uncharted territories. We've got a pandemic looming. We've got a vulnerable section of society, and we've got guidance telling care homes to work closely with trusts to fill up places from hospitals into care homes. Was there ever a time, you think, that you made adequately clear to care homes that they had the option to protect their care homes by saying no?
I don't think it was a message that I ever felt I had to give in regards to that, because the relationship was long established before I came into post at that stage in regards to that communication and that ability. The communication that went to the care homes came from the trusts, who were the contract holder at that stage.
Well, if you might then touch briefly on the Herity report from a slightly different angle, but really picking up on your evidence. You quoted at the outset of your evidence Dr. Herity's findings in relation to the percentages of people being discharged in quarter one of 2019 and quarter two of 2020. My lady, it's a slightly different question than that which I have been permitted, but if I may just expand on that evidence a little bit.
You may.
Thank you. The figure that you gave was, I think, 6% or thereabouts in those respective quarters as a comparison, which pushes back on the idea that the care sector was being flooded, as you say, by patients being discharged from hospital. Behind that 6% figure, if we look at the actual figures in quarter one of 2020, 2,868 patients were discharged following an unscheduled hospital admission into care homes, an increase of 200 or so from the equivalent quarter the year before. The numbers approach 3,000 if elective patients are added to the mix. Firstly, those figures raise the prospect of hundreds of untested patients being discharged to the care sector on a weekly basis in early 2020. Isn't that right?
And that was quarter one. That was before, I think the date on the Permanent Secretary's letter is the 26th of March. So it was actually at the end of quarter one. The figures themselves, I think, indicate that first quarter was actually an increase of 179 for unscheduled care. The second quarter then actually sees from 2019 was 2,660, which dropped to 1,750. So the following quarter, there was actually a drop of nearly 1,000.
Yes, I don't actually want to. There may well be good reasons for that in terms of the numbers of patients going into hospital, and we've heard about that in Module 3. But really, the question is this. If the numbers of patients discharged from the hospital to care homes in the pandemic, that period, including March 2020, remained the same or even increased slightly in quarter one of 2020, does that not suggest that care homes did not or didn't feel able to protect themselves by saying no?
If they had a concern in regards to those patients being transferred at that point, which I don't think was ever indicated, again, as I said earlier, in regards to those patients at that point in time.
Do you understand, and I know you've heard the concerns of the bereaved, that at least until the time that testing was made a prerequisite, which we know I think was on the 19th in guidance on or about the 19th of April 2020, that our integrated health and social care system was, as a matter of fact, prioritising the risks to the health system over the risks to those within the care sector?
I'm not sure I accept that premise. I do realise the concerns that were there, as were articulated by Mrs. Ferguson, or Miss Ferguson's email earlier on, were well articulated in regards to those concerns that were there, and that's why when testing became available and the quantity of testing became available is somewhere we looked at.
Again, Ms. Carey has asked you, and you've referenced the emails from Martina Ferguson, which we know were on the 30th of March 2020 at a very early stage, and you accepted fairly in your evidence that you were aware of those concerns from elsewhere as well. But do you agree that given the obvious vulnerabilities of people in care homes and the known, or even at that stage, the unknown transmissibility of the virus and the risks of contracting COVID in hospital, that the dangers of discharging untested patients from hospitals to care homes should have been more obvious from the outset, as indeed they were to Martina Ferguson?
Well, it's not that they weren't obvious in regards to that. It was how we were able to manage them and actually support those patients in regards to being in hospital where a patient hadn't, or a resident actually hadn't COVID or contracted COVID. The ability to discharge them into a care home, then, back to their own home, the place of safety, was something that wasn't unusual in regards to that discharge policy through, other winter pressures as well, because it wasn't a new policy. It was, I think, a re-articulation by the Permanent Secretary in regards to processes that were already there.
Well, can you see why many of the bereaved might well think that there ought to have been greater protections for the care sector than the ability of individual care homes to say no?
Yes, but I think the ultimate protection, or the ability there, and again, as I've said, in evidence to Ms. Carey, is that ability to say no should be reinforced. And again, I'm more than happy to make it through evidence to this session that if there was a pandemic in the future, that ability to say no should be writ large in regards to any guidance.
I want to move on then to visiting and the care partner guidance, because and we know that the care partner scheme guidance that was issued on the 23rd of September 2020 represented very long-awaited and much-needed opportunity for loved ones to visit their families in care homes, and you accept that. And it came with an expectation that care homes would work towards full implementation by a date in early November 2020. You recall that?
Yes.
How soon after it was issued did you become aware of problems with its implementation and concerns on the part of family members that they were still being denied access to their loved ones in care homes?
Again, pretty early on, because it was a frustration. I've said that in my statement. I would have liked to have seen it implemented, but that's why we gave that 6-week lead-in time. It's also why we gave financial support to care homes as well, and why the recommendation that I've made to my lady in this inquiry, that I believe it should be put on a statutory footing, and that the learnings that we took from that initial period of those 6 weeks is actually underpinned so that everyone understands what the requirements are. My lady, in regards to the care partner arrangement, I think I think some of the challenge that came was that it was a Northern Ireland initiative. It wasn't been tried or trialled or even suggested anywhere else. It was something that it came from the Rapid Learning Initiative from the Chief Nursing Officer. But I do know now that it's actually being looked at in Scotland by way of a private member's bill under Anne's law. It has been discussed in the Oireachtas and in the Government of the Republic of Ireland. So the ability to deliver it and what we intended to do, I still think crucial in regards to what I wanted it to be.
Well, we're not going to disagree on that, Mr. Swan, but if I might just ask you to keep your answers shorter and more focused on the question, just because we do have limited time. Back to how soon you became aware of the problems. On the 8th of October 2020, Mr. Lynch from Cockney wrote to, or the Commissioner wrote to you, and he said, my office has spent the past 4 weeks dealing with calls from families in distress and then angry when care providers could not deliver the access to their loved one, which they believe the new guidelines entitle them to. Home providers, on the other hand, are stating that they are not able to safely facilitate the visiting arrangements outlined in the more recent guidance. So here we are by the 8th of October 2020, just a matter of weeks, and you're aware that the guidance that ought to have been providing comfort and access between residents and families was leading to distress and conflict on the doorsteps of care homes. Do you agree that by the 8th of October there was a reason for immediate action to be taken to facilitate or to address any impasses?
There was, and there was always engagement between families who engaged with the department in regards to that, because we know not only did it contact Copenhagen made us aware, and then the Chief Nursing Officer group who led in this work was able to engage with the homes to allay those.
Well, I want to look at some of that engagement through a series of correspondence issued by the IHCP, of whom we have heard within this inquiry. On the 18th of November 2020, so this is of course after the date by which implementation was expected to have been fully delivered, the Chief Executive of that agency wrote to you about rapid testing in care homes, and she observed in that letter, my recent letters have outlined concerns in relation to the misalignment of departmental visiting policy with the readiness of care homes to increase footfall and relax visiting. So that's on the 18th of November. On the 1st of December, so 2 weeks later, she observed in another letter that the 18th of November letter had not been responded to, and she pleaded with you to, quote, please fully engage with all parties on this issue, and in particular to move forward with rapid testing to enable meaningful visiting. And 2 weeks thereafter, again, she wrote to you on the 15th of December, expressing her extreme disappointment that in the continuing absence of a response from you or your department, on the 11th of December, you had instead issued a public statement pointing to, quote, the reluctance of care homes to introduce the care partner guidance in circumstances where she said the IHCP's efforts to engage with you to find resolution had not received any response, and she requests an urgent meeting. Given the importance to families of finding an urgent way through this impasse at the doorsteps of care homes, why didn't the IHCP's letters and requests to engage receive a direct response from you?
I'm not sure at that point if they were brought to my attention in regards to those letters coming into the department, but I do know there was continual engagement through the Chief Nursing Officers group with the IHCP in regards to care partners, through the Patient Client Council in regards to groups as well.
But Mr. Swan, if I might just interrupt you there. Given how important this was months into this guidance being issued and expected to be implemented, should it not have been brought to your attention that the representative of 50% of the independent care sector was repeatedly writing, asking for engagement and receiving no response?
But there was engagement in regards to those homes. We were working with other care providers as well, whether the direct engagement was with Ms Shepherd in regards to as being the Chief Executive of IHCP. I don't know at this point in time, but I do know there was continual engagement in regards to that. In preparing for this evidence as well, I'm also aware of a a letter from IHCP as well, which on the, I think it's the 18th of November one you referenced as well, where she actually said that adding care partners to the current system will therefore have unintended consequences of actually closing homes to all visits as well. The issue of the statement of the 11th of December was one in regards to frustration from me that I don't believe there was a deliberate delay or stalling in regards to the implementation of care partners, but it wasn't as, I suppose, as fluid and as quick as I wanted it to be.
Thank you. I'm going to move on as quickly as I can because I'm conscious of the time. But in doing so, in response to your observation just now, I should make it clear that many of those whom I represent have concerns about that resistance that they too felt was coming from the care sector, and that more could and should have been done by providers to make it work. But again, following up on the correspondence from Ms Shepherd, on the 7th of January, she writes again, this time under a heading, request for engagement. And she observes that over the last number of months, I've issued a number of letters and communications to the Department of Health outlining the issues that the care home providers are concerned about. Regrettably, I have not received a response to any of my recent communications. And she goes on to list issues that she had previously raised, including testing, lateral flow testing, and the role of the care partner. Given where we now are in January 2020, and we know that problems were continuing and many of our clients were facing those problems, is there any possible justification for the department's apparent withdrawal or refusal to communicate with representatives from the independent care sector who, at least on the face of it, were saying that they wanted to seek a resolution?
No, and I don't think by not responding to those letters, I don't think that the department wasn't engaging with IHCP. I think, my lady, from what I've been made aware of, I think there was 27 meetings with, and I'll stand corrected on that figure in regards to that engagement with departmental officials, with IHCP or their representatives, or indeed individual care homes in regards to that. The fact those letters weren't answered, I can't speak to in regards to this. They weren't letters that came, as you understand, through a private office. They didn't come directly.
Well, finally, just on that note, on the 21st of January, so again 2 weeks later, faced with another non-response, Ms Shepherd emailed your special advisor seeking his help in generating a response or engagement from you directly, observing that she felt she had, quote, exhausted all avenues to try to engage with the department on the issue of visiting in care homes. And so the question really is repeated, is there any possible justification for the department's apparent refusal to engage with representatives of the independent care sector on behalf of families? And it's important that I stress, because families were bearing the brunt of this, to seek a resolution to the issues around care partner guidance. In
regards to, I suppose, the avenues of communication, it was one that I made sure was open to Ms Shepherd in regards to that, either contacting my special advisor or me directly, should she have those concerns.
It was open, but is it fair to observe it was one way?
But no, not in regards to the connection, in regards to raising the issue with my special advisor, because after that I assume action was taken. I don't have the response here with me in regards to that, but that's how the system was operated. But there was, I say, there was that continual engagement between departmental officials at different levels on different issues in regards to those issues that Ms Shepherd had raised.
Thank you. Well, finally then, in terms of lessons learned, and we'll address this with the inquiry and other means as well, but do you accept that one of the key lessons learned for your department, as it was during the pandemic, is that it is essential to take a communicative and consultative approach to the development of guidance, including working in partnership with service users and providers, and that when it comes to pandemic planning, that must start now?
I agree fully, and you've heard the answers and the comments I've made to my lady in regards to the Social Care Collaborative Forum, which I instigated, which was set up and run and now meets regularly. Those bodies are part of it. In regards for preparing for a pandemic, I don't think they should start now. I think they should have already started. They should have started at the end of the last pandemic, where lessons learned should have been reinforced, put in legislation and put in concrete, but I wouldn't want to preempt any of my lady's recommendations.
Thank you, my lady. Thank you.
Thank you, Ms Campbell. Ms Beattie, Ms Beattie's that way.
Mr Swan, I ask questions on behalf of disabled people's organisations and in particular in Northern Ireland Disability Action. And my questions are about testing for domiciliary care workers. Given domiciliary care involved close physical contact and personal care multiple times a day, and workers visiting many different people in different homes in the one day, did you agree with Eddie Lynch, Commissioner for Older People, who wrote to you on the 8th of October 2020, that these workers were in a different position from members of the public and that it was not reasonable to expect such workers to go and arrange tests for themselves in the same way as members of the public did?
I think in the nature of them not working from a single base or a single point of source and often actually working from their own homes, I think that's where that perception may have been. But in regards to the additionality of testing for domiciliary care workers, the Smart NI programme, which we actually launched, which I think has been covered in earlier modules as well, looked to that asymptomatic testing for employees of companies that had more than 10 employees. So the domiciliary care providers, who again are private companies, often subcontracted to individual trusts, could have availed as employers and as companies through that route as well.
Okay, I think that came in later than the 8th of October when Mr Lynch was writing to you, is that right?
That's correct, but again it was in regards to the ability and volume of testing as well. At that point in time, we're still talking PCR tests when Mr Lynch was writing to me, whereas now in regards to what we often, when people start to talk about testing, they often talk about or think back to the lateral flow devices that we had at the end, which was the ease of the device, the availability, the quantity as well.
And Mr Lynch in that letter also told you that this issue of domiciliary care worker testing was directly affecting older people who were in need and receipt of care packages as demand had been affected. So did that lack of testing for domiciliary care workers in effect leave disabled people in the invidious position of having to choose between untested workers coming into their home regularly and performing those personal care tasks, or going without domiciliary care and assistance that might be fundamental to activities of daily living, their dignity, health and well-being?
The testing was supplementary to the PPE that was being provided, and that guidance as well was given to domiciliary care providers through those training videos, through from the Chief Nursing Officer to make sure that they were doffing appropriately the supply of PPE as well. So the testing wasn't the final arbiter as well in regards to people going into domiciliary care homes. The support or people's homes, the support that we put in place in regards to making sure that they had the appropriate PPE, the appropriate training, and that in regards to how they provided their service as well.
And for future planning, given what Professor McBride has told us this morning is a growing population of domiciliary care recipients, some with complex needs who are receiving medical and social care support outside residential care at home, does the need for that cohort for testing and indeed for PPEs you've just mentioned need to be recognised and prioritised?
And again, in one of my recommendations in my statement is actually that plan to prioritise limited testing should the next pandemic or should there be another pandemic, and how the tests develop, how quickly they test, and how available they are as well. So my lady, in my view, that plan to prioritise that limited testing should take into domiciliary care workers and health workers and all other aspects as well in regards to what could be brought forward.
And going back to your comment before about it wouldn't take an awful lot of heads to come up with some of these scenarios, for this issue, would you agree that those heads, whoever they are, really need to understand the lives and the realities of disabled people and how care at home is received, and in fact would really best be disabled people and DPO themselves?
Certainly, I think anything of that level, that once those heads come together, the idea of co-production or co-design, which was always important to me as Minister, is something that should be considered and involved as well, to make sure that those who are going to be affected by it are actually part of it. So, nothing about us without us, I think, was a phrase that was used, and something that I would definitely have been supportive of.
Thank you, Melanie.
Thank you, Ms Beattie. That completes the questions we have for you, Mr Swan. I think you'll probably be quite pleased to learn that's the last time I think that we should be calling upon you. I do appreciate that it's difficult, especially when you have other demanding roles to perform. So thank you very much for all the help that you've given to the inquiry.
Thank you.
I shall sit again at 10:15 on the 28th of July. Thank you.